The topic is low vision in what is new in low vision and rehabilitation in children. So in the past decade, we have seen some changes relating to all these points, whatever I have stated here. First thing is perception about the visual impairment, and the trends in etiology has seen a lot. And also along with that, we have known better about the role of the brain in visual processing. And this has led to our knowledge of adopting various innovative methods to assess these children. Invariably, they have other associated disabilities also. And with that assessment, whatever we found the problems, and then we were able to devise, innovate a program to appropriately to the problems what the child have. And then lastly, I end up with what we are doing during this pandemic. So earlier, traditionally, visual acuity meant only distant visual acuity. We not even mention about the near vision. We just say distant visual acuity. And with that only the whole certification of blindness, everything is here in place. So, but now we have moved on to the fact that the vision is not only the reduced vision or the visual fields, but now we are moving on to recognizing the functional or the residual visual function what the patient has. So that is further advantage for us to look into this problem of functional vision. So this, with the functional vision, if we have the same, supposing you have two patients, the same etiology, the same visual acuity, and all other things same, but with the NVDAs or LVDs, you will see both of them taking a different time or different functionalities in finishing whatever the task is given. So that depends upon how they comprehend the situation. This comprehension depends upon how other visual functions are. So leave alone the distant visual acuity. Now we realize the vision as a combination of senses, including all these visual functions. So even despite of a good visual acuity, there are children having difficulty in reading, difficulty in accomplishing their work, academic work, because of either the contrast or glare or cognitive visions or defective in the circuits or pursuits. So how do we now the stage where we have moved from stating the visual acuity only, we are now going to the stage of stating as the visual functions as having a comprehensive part of vision, and it's not only a single entity. So, but whatever it is, these aspects are not included in the public community-based screenings, either in the schools or anywhere else. So these functions are not being included. We are now not able to recognize this group of children where we can do a lot of things to improve their thing. So now, few years, we have started screening the children in the school, identify special schools, identify their own specific problems and address them. Definitely that improves their quality of health. And regarding the etiologies, we are thinking we have shifted a lot to from causes from as a nutrition and malnutrition and infective causes to we see retina and cortical causes. In this tells us that we are nowhere behind the developed countries. We are almost near the developed countries, or almost even bypassing the developed countries, where the brain lesions are now predominantly causing visual impairment. So this is where our center of focus now has become. So also why that is more important, as you all know that 50% of the brain is involved with the two pathways involving almost all the lobes. One is recognized for what the shapes, shape and size, color and objects, and the other is for the cognitive moments. So why this is important? Because when you recognize some defects in some part of the functions, it's possible that we can focus on the other functions in the other part of the brain. That brain can be stimulated if we identify children in the plastic period. That is the value of understanding the role of brain in visual processing. And if you speak traditional rehabilitation, what we were doing earlier, it was consisting of only giving visual aids, telescopes or magnifiers or high-end glasses for distance, or giving all sorts of magnifiers for reading, and at the most giving tinted glasses or do a mobility screening. But what does it now comprise? So breaking conventional rehabilitation, now we are into rehabilitating or debilitating on a need-based. So that is more important. Now, for where to start for this need-based rehabilitation. So instead of going with the visual acuity, you ask the patient what exactly they need. A 60-year-old may need a different thing to see somebody coming into the house by using some telescope or something, or he might be interested only in reading. But a 10-year-old will be interested in going about mobility and then going to school. So we don't label them as blind, whatever depending upon the visual acuity. But we try to give either the low visual aids or the non-optical devices and or environmental adaptation depending upon their problems. That is called a need-based rehabilitation. And this is one more condition where in progressive conditions, earlier when we see RP, we used to ask them to come regularly for checkup and then give them whatever device for that stage possible, we just give them. Now we look into the future of these people and try to teach them whatever is possible with the vision what they have, and anticipating their visual impairment in future by teaching them alternative methods and by preparing them for a future quality life. And this is very best can be done by visual concepts rather than teaching after they become blind about using only the auditory and tactile senses. It is more important now. So what is it? These children usually, they don't come for rehabilitation as they are very early, and you would have seen children in even blind schools. They walk, they never have used the stick like this was as the adult do it, because the rehabilitation starts only after they reach 18 or 20 when they go for vocational training, not in the schools. Now we start because to avoid the social stigma, try to get the local devices and then make the children use as their infants. This is what rural or urban areas, wherever it is, it can be available. And this child can be used. This is what we used to play when we were young. And this child, earlier the can was not available, a pediatric can. We have modified the adult can and then we have made them use this pediatric can. This will definitely improve their quality in their later age groups. And children with disability, if they are not intervened earlier, invariably their growth, the global development will get affected. So when that gets affected, they become mentally, emotionally, and socially crippled child. So the intervention should start even with perception of light. So when they have even perception of light, we should not say this cannot be improved. So just by light stimulation, getting an ambulant vision like catching or reaching for object or walking, there should be enough for that particular child. So what we have done is a format where we have developed a form to assess the functional vision of these children, and includes basic manual kit, what's called LIA kits is available. It includes all the shapes, shape and other recognitions, pursuits, circuits, movement, contrast sensitivity. Whatever I described earlier, these children are being tested. Though it is long time consuming, it is worth doing it for these children. And now with the difficulty of doing manually as it takes longer, we have a software has been developed. It's called Vision Intervention Kit for specially needed children. And this is iPad, any iPad can be used. And all the tests, whatever it has got, at least around 20 tests, which is from which we can detect almost all the functions under the functional vision assessment. And this also can be used for the training also. The parents, even they can assess. If you could tell them they do these exercises, they can do it at home. And what is this Dignify? This is a recent one where this is to train these people use mobile for reading a book. And this is very good in reading because it goes, even if you stop, you can stop, go back to the, if you want to go back to the previous page, it can go. You can fast forward, you can stop and ask for the spelling. So everything can be done with that. It's got a stand, you can keep the book and then you put the mobile on the top of it and then read. So this is a long video. And the next thing is training them in computer technology. This is because without this technology, these people cannot be placed in any company in a normally acting, normally working companies. So this is what now we focus is the stand, the mobile phone and the book, they keep it down. And this, this child is a sibling of the older child. And this child wanted to try, we thought this child may not be able to do it. She is only 5-year-old, a case of LCA. And then she fantastically improved it in computer training. Usually we give around 60 hours of computer training in all the NVDA aspects. And then we give a certificate along with the non-profit organizations. And these people are ready for going for jobs. This child can read, can go to normal school with a laptop and then do anything what the child wants. So they choose what they want. We cannot dictate. This child may not be possible to do the rehabilitation. And what is this? Now this artificial intelligence has come everywhere. And now this is called Arkham, say spectacles. With the spectacles, you can read, you can recognize faces, you can see, and then you can photograph, you can have a memory card, and it recognizes once you do it, keep a photo inside, it can tell you, oh, somebody is there, or Dr. Vijaya is there, or Dr. Azim is there in front of you, or a male is there, a female is there. But this is very expensive. But recently, India, in Bangalore-based company, they have come up with this smart vision spectacles, which is very good to use it, and people are happy about it. And what about now the children who are already in Braille? This Orbit reader has come recently, which can translate, which can print out Braille into normal print or a normal print into a Braille. But see how long they have to press for the Braille. Braille needs a lot of pressure to type it. So this is very difficult to type everything. So in Braille books, they can easily copy it in this Orbit reader and then they can read. And a normal book also can be done in other ways also. So in general, what is it? The stereotype of giving only low visual aids or NVDAs should be done on need-based with the background of mainstreaming them into a general population and making them do any job given to them as a normal individual. So, but after COVID, what we did was we could not get the patients because they, the difficulties. So we started doing online computer training. The same amount of 60 hours training we were giving online, and also the vision therapy. What children with CP or PVL, whatever patients, and the teacher, the special educator is there. And the child, earlier we tried WhatsApp, now we are trying with Zoom, and it seems to be working well because we don't lose the contact. Continuously they are getting, otherwise they go back to the, yes, I am finishing. So as a clinician now, Subhatra said there is a lacuna that we should do something. So what we should do as a clinician, this should be done. And as we do, maybe we should work with the neonatologists or pediatricians to develop some program where the children discharged from NICUs have a long-term follow-up to identify these children at the earliest and refer them. So that should be our motive or a take-home point for all of you, those who are in the program side, to plan for the programs. If we achieve that, I think the early identification will be very nice, and then influence on the quality of life will be much better for these children. Thank you very much for giving me time and giving me this opportunity to talk to you. And this topic has become a passionate one for me recently.